Alrighty, Module 5, supraventricular arrhythmias. Let's get started. Supraventricular arrhythmias are heart rhythm disorders that start in the atria. So the key thing here is they have narrow QRS complexes, and this is super important. When you go to look at an arrhythmia, you don't know what it is, it's a rhythm strip, you're given it on a test, one of the things you're going to want to look at is the QRS complex narrow or wide. If it's narrow, it's going to start above the ventricles, supraventricular. If it's wide, it starts in the ventricles. And that can help you kind of categorize these different arrhythmias that we're going to talk about. So supraventricular arrhythmias, they can be triggered by loads of things. And they can also occur spontaneously without obvious triggers. Premature atrial complexes, again, they can occur for a number of different reasons: diet, fatigue, stress, disease, ischemia, etc. But they occur when an early electrical impulse occurs from a location in the atria other than the SA node. So you have some other spot in the atria, not the SA node, that is kicking off this complex, okay? The early impulse causes early cardiac complex, which disrupts the underlying rhythm. Different location means different morphology of the P wave, okay? So R to R interval is irregular. The fifth complex is early, and the P wave is on the early complex is a different shape. So if we look here, and we look at our R to R interval here, it's pretty easy even to eyeball this, right? These two here, clearly closer together than these guys over here. So when you see that difference in R to R, now you get to investigate, okay? So these are all pretty regular, and then we have this beat that comes early. When we look at it, this is our P wave. Does that P wave look like the rest of them? No, it looks different because the complex is coming from somewhere other than the SA node. It's kicking it off early, but we have a P wave. That's important. We have a P wave, we have a QRS complex, it just came early. And it looks a little bit different than the others. That is a PAC. Now you can be having PACs with or without a pattern. Here we have a pattern. So we have beat, beat, pause, beat, beat, pause. This would probably be the same, beat, beat, pause. And it would continue, so on and so forth. But notice again, this is our normal P wave. This is our funky P wave. Normal, funky. So we have that patterned approach. The other thing that you can think about when you look at the PAC, if you were to take this complex here and just scooter over a little bit, you would have a regular rhythm. So the defining complex or thing about a PAC is it is premature. It is a complex that is just beaten a little bit early. But if it, behaved and it was on time and it was coming from the SA node, you would have a regular rhythm. All right. Premature junctional complexes, or PJCs, these and junctional escape beats may occur for, again, a number of different reasons: diet, fatigue, stress, disease, ischemia, etc. The PJCs occur early, causing an early cardiac complex, which disrupts the underlying rhythm. This should sound familiar. It's very similar to your PAC. Now, the difference here is junctional escape beats typically occur when a cardiac rhythm is too slow and a backup pacemaker site initiates an electrical impulse. PJCs can be observed with or without pattern, just the same sort of thing. So if we look at this first example, we have R to R to R. Here, these are clearly closer together, and then we resume this normal pattern. And again, if we were to scoot this guy over, we would have normal regular rhythm. But it's arrived early in the pattern, and then we resume the pattern afterwards. Notice how this doesn't really have a P wave compared to the other guys. This has sort of an inverted P wave that happens directly before the QRS complex. A little bump in the road right before your QRS complex. That's a junctional complex, premature, okay? And then we have here, we've got a pause. And then we're going to have that initiation of the junctional escape beat to bring us out of the pause. All right, atrial flutter and fibrillation. Let's first talk about reentry versus chaotic activity. So atrial flutter is caused by large, organized reentrant circuit. Produces rapid and regular atrial activation. This is also called macro reentrant tachycardia, where electrical impulses travels in a continuous loop, activating the atria in a predictable pattern. It's very, very important here. So if we look at our diagram over here, we've got this signal here in the right atrium, and it goes woo, 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 round and round and round and round and round, and goes through. The AB node decides what lets through, and we'll talk about that more. But we've got this reentry. It's going round and round and round and round and round. Okay, atrial fibrillation, however, is characterized by chaotic, disorganized electrical activity in the atria with multiple small wavelets of activation occurring simultaneously. Now, this can either have rapid focal firing or multiple reentrant circuits leading to the loss of coordinated atrial contraction and highly variable conduction to the ventricles. So if we look at our little diagram over here, we've got this party going on over here, and it's kind of wild and it's kind of chaotic, and some of the things go through and create the whole system. Now, another way to think about this, think about like your SA node is ringing a bell, right? And it's ringing that bell at 60 to 100 beats per minute, and it's going to be nice and constant. Now, when you get an atrial reentry for your atrial flutter, you've got this other part that's like, hey, I want to have a party too. So I'm going to ring that bell with you. We're going to like continue in this nice little musical flow circuit right here in the atria. And then some of those will get through. But yeah, we're going to do this nice organized like little musical instrument circuit thing up where we're doing it. So we get more than one bell, right? Versus atrial fibrillation, you got to think about like a kindergarten class was just given access to all the handbells in the school, and they're just going absolutely bonkers. They're going all over the place. That's more of your atrial fibrillation. So fibrillation is more chaotic, it's more unorganized, it's not controlled, versus your flutter is going to be very predictable, very organized. Let's look at some of the waveforms. So sawtooth flutter waves are kind of what characterize our atrial flutter. So atrial flutter occurs when there's an obstruction within the atrial electrical conduction system. Due to this, a series of rapid depolarizations occur. These may occur 2, 3, 4, or more times per QRS complex. The AV node functions like a gatekeeper. This is very important. Gatekeeper AV node. It blocks the extra impulses until the ventricular system is able to accept the impulse. So the impulse that is accepted will then cause the QRS complex to occur. Now, we don't measure a PR interval here because there's not really a PR interval measurement. But if we look here, we've got this sawtooth pattern happening in a predictable manner all before our gatekeeper AV node allows that QRS complex to go through. Versus irregularly irregular AFib. Say that again. Irregularly irregular AFib. This occurs when multiple electrical impulses occur within the atria. This is chaotic electrical activity resulting in chaotic waveforms between the QRS complexes. The P waves are absent. You have rapid electrical activity. It overwhelms the AB node, causing impulses to enter the ventricular conduction system at irregular points, which gives you your irregular R-to-R intervals. When a patient is in AFib, they can have a loss of cardiac output anywhere from 15 to 30% due to the absence of the atrial kick. The body increases heart rate to maintain homeostasis. Lots of things clinically that we can talk about at another time. So when you get this rhythm strip, I want you to see your R to R is irregularly irregular. There is no pattern to these R to R intervals. And then we've got this sort of like squiggly going on for our like baseline, rhythm. Remember, think of those kindergartens. The kindergartners just came into the class, they took all the handbells and they're going ding, 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 rapidly, chaotically, crazily. So we've got this like squiggly line and then a narrow QRS. Irregularly. That is AFib. Irregularly irregular. If you see an exam question and you see irregularly irregular, first thing you need to be thinking of is AFib every single time. And you can investigate beyond that, but irregularly irregular AFib. All right, last here is SVT and junctional tachycardia. Supraventricular tachycardia, your electrical impulse is again initiated above the ventricles at a rate of 150 to 250 or more beats per minute. QRS complexes will remain normal appearing at a rapid rate. The T waves of the previous SVT rhythm complex will cover the P wave of the next, and the P waves are entirely buried, making it impossible to describe their morphology or measure some sort of PR interval. So we can see here we have an extremely fast rate here we are like one box. So this is practically 300 beats per minute, right? One large box apart. And then we've got this morphed T and P complex here, and we're just going boom, 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 boom. Supraventricular tachycardia. And then we have junctional tachycardia. This is going to be an accelerated junctional rhythm. It's going to arise from enhanced automaticity in the AV junction. You've got, again, those rapid, narrow, complex rhythms. P waves may be absent, they could be inverted, they could be dissociated from the QRS complexes. Here you kind of got this flatness to the P wave that you can visualize here, or we've got these little humps that are like right before, like it was thinking about being a normal P wave, but really it's too short to even call it such. So junctional tachycardia. This is one of our junctional rhythms or junctional variants. All right, that's all I got for you on this one. Put it in the comments if you have any suggestions for things you'd like to see in the future. Otherwise, we'll keep making these and we'll keep helping you learn EKGs. Best of luck in your classes. Bye.